This time I'd like to introduce the proof of concept stage of idea about MSK embolization in future might be imageable, bioresorbable one. So this is my disclosure. There are two types of procedure for MSK embolization. One is a conventional using microcatheter super selective MSK embolization. The other one is US guided simplified embolization using a direct puncture to the target near the target lesion artery. So first one is selective MSK embolization. This is movie during the we treated the hamstrings injury, proximal hamstrings tendinopathy. We inserted microcatheter into the obturator artery, and we can see the brush like this, and we can deliver the microsphere or embolic material to this target lesion. This is a conventional one. The other one is US-guided simplified embolization techniques that can be showered from the proximal point or near the target lesion. This is a movie during our treatment to the finger osteoarthritis, hand osteoarthritis. This is only using ultrasound, and just like this, we can see the radial artery using a short axis, and just using a small 27 gauge needle and puncture and infuse. We only use the imipenem software. Maybe Lipiodol is also feasible. But this is a color change after the immediately of this procedure. You can see the recovery of the blood flow of cutaneous tissue within several minutes. So it can be feasible by using like imipenem, like quickly soluble particle. And we also do to the plantar fasciitis, using the same manner, puncture the PTA, posterior tibial artery, like this, and infuse imipenem from here. So by doing this, we can reduce the cost, and it can be done in a consultation room. So it's very easier technique. So we have already published some paper about these results like this. Anyway, so in future I think we will combine this technique like super selective for many joint, and also doing some extremity joint, like using puncture, direct puncture. So the biodegradable is one ideal characteristic. The other might be X-ray visible or ultrasound visible. We don't have so far the good substance that can be visible, imageable for the fluoroscopy. We have never tried, but now this time I will introduce some candidate of this. This is a Novosphere from Clear Dynamic. It's a glass piece. Inorganic polymer and bioresorbable and calibrated particle size now is range with mean particle size is more than 100 micrometer. And this particle is glass, made by glass, so non-compressibility. There is no compressibility about this. So we studied by using a swine kidney model, by using couched access and 1.7 microcatheter, super selective to the kidney renal artery, and we assess the delivery, ease of the delivery and microsphere imageability in fluoroscopy and on cone beam CT. This is a movie during infusion of this particle. We don't mix with contrast, just mix with saline and glass beads. You can see the delivered microsphere, glass microsphere like this. It's very X-ray visible during the particle infusion. And this is a cone beam CT after infusion of this particle to the upper part of the kidney. And you can see it's very fine, thin artery embolized. Also, we don't use the contrast enhance this time. So this piece clearly visible on the X-ray, and also we assess the microsphere imageability on ultrasound for the direct puncture procedure. And also we use a balloon, and to block the we want to avoid the area. So this is a summary, the common femoral artery puncture. We inserted the Cs, and the superficial femoral is a target, and deep femoral is we block with a balloon. And we infuse this particle, the very strong ultrasound imageability compared to imipenem, and like this. And also we tested to whether we can aspirate the excess microsphere like this. This is a movie during the aspiration. We can see the aspiration of excess microsphere like this. So please understand this is a proof of concept, but we try to apply this technique in future. So the third one is posterior tibial artery puncture model. So we use and the imageability of ultrasound and cone beam CT. This is a short axis PTA, and doing the infusion of this material. Again, the very stronger imageability compared to imipenem. And we also do the cone beam CT after 10 minutes of the procedure. We can see the remaining of the particle. It's X-ray visible, so we don't infuse the contrast, but we can see well about this. And we also can confirm the particle remaining in the artery for the ultrasound too. So what difference will this new embolic substance make? First one is maybe we can discuss about the greater standardization of embolic endpoint due to the visibility of the embolized position. Because we can discuss this case, we only block this area, or in this case we block the other artery or something. And the other point, easier confirmation of embolic material reaching the target site. Because nowadays we use imipenem for the puncture shower model, but the negative point is we cannot confirm the reach to the target region. So we can have some confidence about reaching the target area. So future direction is finalized on non-clinical data about safety, and especially is adjusting biodegradable time. It's very difficult sometimes. So it's now the stage of proof of concept, but after can develop the good condition of biodegradable particle, we can test to the human for the first trial. So thank you very much.
Questions from the audience? If not, then I have a couple. We have 5 more minutes, so I have a couple of questions. One is, you said this is a biodegradable embolic agent, right?
Yes.
And
yes.
you said you can vary, based on the properties of what you make, the degradable time from 2 minutes to 24 hours.
Yeah.
If you're working in a joint, what are you aiming for? What would be a clinically useful biodegradable time? Would it be a couple of minutes? Would it be a couple of hours? Would it be 24 hours? What are you aiming for? And
yeah, so it's a very difficult point because, for example, imipenem. Imipenem is not a time-dependent manner, but volume dependent. So imipenem particle is crystalline, and which can be resolved within a second if the particle with contact with a large amount of fresh water. So and this particle is made by glass, and it's difficult to determine the degradable time on the bench and in a human body or in vivo is very different. So we have to confirm the real degradable time in the like animal model too. Yeah. So it's very important. So it often differs from the bench and the intra-arterial.
You showed these beautiful pictures of the swine kidney with the kind of nice radiopaque vessels. Have you studied how long it takes before it disappears, or was this in swine cadavers?
Yes, that is, thank you so much. That is next our plan to directly confirm how long this material, and maybe we need some adjust or something,
And then the second point is, can you produce this in different sizes? Can you go like from 150 to 200 and 300 to 500 and so on? And if yes, what sizes are you aiming for?
Yeah, thanks so much. That is also an important point. I think I'm not an expert about the chemicals of this material, so I don't know well actually, but it seems to not so easy to control the size. So now we are available the 110 or something, but maybe in near future we can adjust that. And if we can adjust, we want to block larger than 100. Larger than 100 is important. But the other point is that this particle is non-compressible compared to the other, like gelatin or permanent acrylic or something. So we have to consider about that too.
Thank you.
So for the future development, what's the route? I mean, you think that these particles may be an advantage over the already existing resorbable particle, or so you're planning to do in vivo studies?
Yes. So thank you so much. So I think we now, because I'm curious about the develop or progress of MSK embolization, so now I'm considering to adjust this particle to the future MSK embolization, but we are not sure this is feasible or not. But we try to, after confirmation of the safety and biodegradable time, I will move to the human MSK disease, if I can.
Thanks again, Professor Okuno. And with that, I'd like to conclude this short but sweet session, and we'll proceed to the next session. Thank you very much.